increased PTH effect, which is a rarer form as compared to the impaired PTH effect, but it has got significant implications. So what are the more common causes of increased PTH effect that you would see, Dhwani?
So calcium sensing is
So most common would be the neonatal severe form of hyperparathyroidism. What else? No, so increased PTH of a secondary is not an increased effect per se. That we have discussed. That will be rarer. So then older children, you will get more likelihood of adenomas, which will be there. And then what about men? What is the usual presentation of men?
so in this 40s they will present.
So it is very, very unusual in children. How is pediatric hyperparathyroidism different compared to adults?
So pediatric is I think this is more multifocal
Yes.
in comparison to the adult, and
more likely to be genetic and high risk of recurrence. So this is very, very important. So what does it mean is that if you have a single lesion in a child, you may still have many small lesions which may not be picked up. So that's why a scan is not a very good modality in pediatric age group. And we would recommend usually a near total subtotal parathyroidectomy on that regards.
So these hyperparathyroid guidelines are based on this 5th International Workshop, these summary statement and guidelines published in the Journal of Bone and Mineral Research and the American Association of Endocrine Surgeon guidelines. So regarding how should we make the diagnosis of hyperparathyroidism is very important. And the guideline clearly says, that as Sir said, that there are hypercalcemic and normocalcemic variety. So when there is a elevated serum calcium adjusted for albumin, when there is a low albumin, so we have to adjust it for the low albumin by using the correction factor of 0.8. In the presence of elevated or inappropriately normal intact PTH, on at least 2 occasions, which should be at least 2 weeks apart. And in the normocalcemic PT, normal adjusted total calcium and the normal ionized calcium along with the elevated intact PTH, and these should be at least on 2 occasions over 3 to 6 months. And after all the alternative causes for secondary hyper-PTH that have been ruled out. For the confirmation of the diagnosis, we made the biochemical investigations, which include adjusted total serum calcium, phosphorus, intact PTH, 25-OHD, and the creatinine. And for the skeletal images, we use 3-side DEXA that includes lumbar spine, hip, and distal 1/3 radius, and imaging for vertebral fractures. And the TBS, that is the trabecular bone survey, it would help in the evaluation of the vertebral fracture. This renal evaluation is very important, and we can either do the estimated GFR, but preferably creatine clearance is done. Full 24-hour urinary calcium is required, and imaging for nephrolithiasis. And in those with hypercalciuria, a stone risk profile is required. And as in pediatric age group where the hypercalciuria is said when their urine calcium is more than this 4. In adults, it is in women, it is more than 250 milligram per day, and in men, when it is more than 300 milligram per day. So as we know, that the clinical manifestation of hyperparathyroidism, it will present with a joint pain due to osteoporosis, fractures, renal colic and chronic kidney disease due to the renal calculi, pancreatitis due to hypercalcemia, proximal myopathy, and the asymptomatic calculi that has been found in the ultrasound that is done for any other cause. Now, the role of genetics, it's very important to assess when we should go for genetics. The guidelines clearly said that the genetics is not required to make the clinical diagnosis of hyperparathyroidism. It should be considered in only the following conditions. When the patient has hyperthyroidism and the age is less than 30 years, when there is a multi-gland disease by history or imaging, when there is a family history of hypercalcemia of men 1, men 2A, men 4, hyperparathyroidism jaw tumor, when there is an atypical parathyroid adenoma or carcinoma, And in cases of hypercalcemia, because in those cases, surgery is contraindicated. So genetics is required in these scenarios. So now coming to images, when to perform. As sir has already explained that images has no utility in confirming or excluding the diagnosis of PHPT. And it should not be used to select the patient for even surgery. And patients with negative imaging results remain candidates for the parathyroidectomy. So the question comes when we should go for imaging. Imaging is only performed after deciding to proceed with parathyroidectomy and is performed for operative planning only. Now, what to perform? It is really a challenging question. Like those candidates who are the patients who are candidate for surgery and have negative or discordant images, they should ideally be sent for the parathyroid surgeon for evaluation. Cervical ultrasonography is recommended to localize parathyroid disease, and it is a very cost-effective modality. But preoperative parathyroid fine needle aspiration is clearly not recommended, clearly in the cases of parathyroid carcinoma. The technician systemic scan is the dominant isotope in parathyroid scintigraphy, and each systemic protocol dual phase iodine 131 subtraction, that is the including the thallium dye in this protocol, is a useful modality. Combined ultrasonography along with the systemic scan increases the localization accuracy, and a 4D dimensional computed tomography has emerged as a useful modality.
If you are thinking of hyperparathyroidism, will you do a scan directly if you want to do a localization or ultrasound first?
So if we are in a place where we don't have access to this scan, we can go for cervical ultrasonography. There is no harm in that. If we find a lesion that's good enough.
Dr. Rishi saw in the IQ. Yes. So he had a tertiary hyperparathyroidism.
I see primary.
Primary.
But he had a renal disorder for a long time.
It was palpable, right? No, it was.
Nodule will happen.
Yes, sir.
The tertiary also will develop.
Yes, sir.
Now study renal failure. So ultrasound may pick up.
Yes, sir. And
one important message you said, FNAC should be avoided.
Avoided, definitely. Now coming to what are the indication of parathyroidectomy? All the symptomatic patients are the candidates for parathyroidectomy, and when the serum calcium is more than 1 milligram above the upper limit, that is a 10. So if the 11 is the serum calcium, it becomes the indication. And when there is a renal involvement, in case whether it is silent nephrolithiasis on renal imaging, nephrocalcinosis, hypercalciuria with increased renal stone risk, or when there is reduced GFR, that is less than 60 ml per minute. And when they have osteoporosis, fragility fracture, or there is evidence of any vertebral fracture, compression fracture on spine imaging. When the patients are diagnosed at 50 years or younger, regardless of whether objective or subjective features are present or absent, and in those patients also who are unable or unwilling to comply with the observation protocol, so who could not be monitored for a long time, they become the candidates for the parathyroidectomy. Now, they are important to know what should be done pre-operative and during the intraoperative. In the pre-operative, a daily, as we know that hyperparathyroidism is a condition where the calcium is high, but the guidelines clearly says that even in the case of PHPT, a daily intake of 1000 to 1200 milligram of calcium is recommended for adults and appears appropriate for the patients for the PHPT as well. And if before the parathyroidectomy, the patients are vitamin D deficient, then they should be supplemented with the vitamin D. And the patients who present with hypercalcemic crisis, they should medically managed for going for the hydration, then furosemide, cinacalcate, and then followed by the parathyroidectomy. Intraoperative management is important to look for. It is basically an image-guided focused parathyroidectomy. In this, the intraoperative PTH monitoring is done, and it is suggested, this monitoring is suggested to avoid the higher operative failure rates. In addition, the intraoperative PTH monitoring is useful in making a difference between the differential jugular venous sampling and ex vivo parathyroid aspiration during the surgery. And it should be keep in mind that when the surgeon is doing the intraoperative this parathyroid monitoring, should use the sampling protocol that is reliable in the local environment and should be familiar with the interpretation of the PTH decay dynamics. As we know that PTH decays in the room temperature. So both the before the thyroidectomy and the intraoperative PTH should be this interpreted at the same room temperature. Now, coming to what surgery choices we have and what they are indicated for, the minimal invasive parathyroidectomy is done. It is basically the focused approach, and it is done to the patients who are clinically and by imaging to have a single parathyroid adenoma. And if during the surgery we find that there is a multiple gland involvement and there is an inability to identify an abnormal gland, or there is a failure to achieve and decrease in the intraoperative PTH decrease. So definitely this minimal invasive is converted to bilateral exploration. And the bilateral exploration is definitely for a non-localizing preoperative imaging when there is a high suspicion of multiple gland involvement and when the intraoperative PTH is not available or at the discretion of the surgeon's decision. In the MEN 1, this subtotal parathyroidectomy is recommended, and MEN 2A, it's only the resection of only visible and large parathyroid glands is recommended. Now, the post-operative, sir, it has already been covered by the sir. It says that calcium intake should, after the surgery, the calcium intake should follow the Institute of Medicine dietary references. And vitamin D deficient patient should receive vitamin D supplementation after the surgery. And this is important to know that with patients with transient hyperparathyroidism after the surgery should be treated with IV calcium or oral calcium and supplements of calcium and should be weaned as tolerated. And the patients with prolonged hypoparathyroidism, this recommended PTH therapy is considered. The patients are monitored at 6 months along the surgeon and the multidisciplinary team to assess whether the surgery is a cure or it's a failure. So this monitoring at 6-month interval is important.